Welcome to tonight's town hall on prevention. I'm Mike Gibson. I'm an interventional cardiologist and run the Baim Institute, a Harvard affiliate for clinical research, and professor of medicine at Harvard Medical School. I'm joined by a couple of our esteemed faculty tonight. Next slide. This is a town hall meeting. It's live. It's meant to be interactive. We'll also be posting it on clinicaltrialresults.org, where it will be archived. Everyone has put their slides together independently, so all the members of the faculty have complete editorial control over the content. This activity is funded, though, by an independent educational grant from Aspirion and Amgen. Next. These are my disclosures. Again, I run a research institute at Harvard and have disclosures from a lot of different manufacturers of devices, antiplatelets, antithrombins, and lipid-lowering agents. Next. All right. Well, let's meet a couple of our faculty members. Anne-Marie.
Hi, thanks, Mike. Great to be here. I'm Anne-Marie Navar. I'm a preventive cardiologist at UT Southwestern Medical Center in Dallas, Texas.
Great. Thanks for coming on, Anne-Marie.
Oh, and these are my disclosures listed here.
And I'm Pam Taub. I'm a cardiologist and professor of medicine at UC San Diego in La Jolla, California. And it's great to be here with you, Mike and Anne-Marie. And then these are all of my disclosures. And so let's get started.
Yeah, so I think tonight we really want to talk a lot about LDL lowering and some of the hot new trial data coming out of ACC 2024. That's kind of the present, but we also want to look to the future, and we're going to count on Anne-Marie to guide us there. So why don't we get started looking back at some of what came out at ACC? Let's begin though with the guidelines. I think you're going to start with the guidelines, Pam.
Yeah, but before we get started, I think Anne-Marie's going to give us a good question for the audience.
Yeah, so keep in mind, we won't give you the answer just yet, but according to the guidelines, and we're specifically talking about the latest AHA-ACC multi-society guideline for cholesterol management, what makes a patient very high risk for future ASCVD events? And Pam, go ahead and click through these options and I'll just read them through. History of ischemic stroke in somebody over 65 with diabetes. A history of an MI, a smoker with a persistently elevated LDL, a DVT with hypertension, or both B and C. Next question we have to think about, oh, and then last answer is A and B. Next question we have to think about is really thinking about LDL targets. So after a cardiovascular event, what should your LDL cholesterol level be? Sort of different thresholds as options: 130, 100, 70, 55, or lower. So Pam, let's talk about the guidelines and tell us what at least we are supposed to do as of today.
Well, the guidelines are always evolving, and I think in 2024, we have a lot of different options for LDL lowering. And I think even though we have some differing guidelines that may vary in terms of the target LDL, the themes are the same, where we really want to match the intensity of the lipid lowering with the risk of the patient. And here is where it's really important to assess risk. And we do have the 2022 ACC Expert Consensus Decision Pathway that is the latest update. But again, even after this was done, lots of new data has emerged, which is going to also modify the guidelines even further. So let's look at what they say about patients who are at very high risk. First, the new change is they recommend getting to an LDL-C less than 55. And again, 55 isn't your perfect number. It's really the minimum number or minimum threshold that you want to achieve. So for my patients, I really aim for a lower LDL. I get the LDL into the 30s if I can. And I do that usually with multiple agents. Statin monotherapy typically isn't enough to get the LDL where I want it to be. And by utilizing multiple agents, sometimes you're able to also decrease side effects. So for instance, there are many patients of mine that can't do high intensity statins due to musculoskeletal side effects. So I may lower the intensity of the statin, but then add on other agents such as a PCSK9 inhibitor, inclisiran, ezetimibe, or bempedoic acid. And what these guidelines suggest is for these patients, after you get them on a maximally tolerated statin, here's where you want to consider other agents like ezetimibe, PCSK9 monoclonal antibody, and they also now incorporate some of the recent data from bempedoic acid or inclisiran. I think the key here is that we need to be comfortable with combination therapy. We can no longer be stuck in this era of statin monotherapy and just trying to maximize the statin and keep up titrating it even when the patient tells us that they're having all these side effects. It's really important that we try to minimize the side effects because that really leads to long-term adherence. And one other new concept that was incorporated into the ACC expert consensus statement is this concept of risk stratification, and that even patients who haven't had an event, there are ways to assess their risk. And coronary artery calcium scoring is a non-invasive, relatively cost-effective way of looking at subclinical atherosclerosis. And I think this is really where our field is heading, and that we're going to be focusing more and more on patients that are high risk and how do we prevent the first event instead of just focusing on treating patients aggressively after they've had the MI. And here what we see based on a recent paper is when people have a CAC score that is over 300, that patient carries the same risk as a patient who's had a myocardial infarction or stroke. So this is a really important concept. And the guidelines have actually incorporated coronary calcium scoring into our decision making. And so here they look at a CAC score greater than 1,000, but I think the future reiterations of the guidelines will look at lower calcium scores, maybe greater than 300 based on that study that I just showed. But here what they say is it's reasonable for these patients to add on agents such as a PCSK9 monoclonal antibody. And what's really nice is I have now been able to get these drugs approved by citing this expert consensus statement. So this is really nice that we're starting to move more upstream into prevention. And so let's talk about who is very high risk for future ASCVD events. We know that a patient that's had a recent MI, recent ischemic stroke, patients with PAD are all very high risk. And sometimes we forget about PAD because we think that it's not as serious as CAD. But what we've seen from registries like the REACH registry is that patients with PAD are often undertreated and have higher risk. And so to be classified as very high risk, you can have a history of multiple major ASCVD events or one major ASCVD event and multiple high-risk conditions. And that includes things like diabetes, hypertension, CKD, and this is just an eGFR less than 60 that counts as CKD. Those that smoke, those patients who have high LDLs over 100, despite being on statin therapy and ezetimibe and congestive heart failure. So these are all really important features that we should be thinking about when we're seeing a patient and when we're classifying them as high risk or very high risk. And for our very high risk patients, we are really going to be pushing those LDL levels as low as we can. So
now, Pam, that slide, that was from 1999. The guidelines added in the calcium score. So if you were to integrate in the calcium score here, where would you put it?
I would put it under a very high risk condition. and would say that if you have, you know, a major ASCVD event and you have a high calcium score, I mean, that's puts you in it. But the problem is this isn't the right place for calcium scoring, because this is already looking at patients who have had an event. I mean, you almost need another box that says patients without an event that are very high risk. And that's where I think you could put in calcium scoring. You could put in some of these very high risk conditions, also risk enhancing features such as metabolic syndrome, ethnicity, such as being South Asian, having inflammatory conditions like lupus, rheumatoid arthritis, that elevates your high sensitivity CRP. So I think that you almost need a separate box for this, what I would call high risk primary prevention. And Anne Marie, your thoughts on that?
Yeah, I agree. I would actually have, you know, secondary prevention, which we've now sort of split into very high risk versus not. Primary prevention with its risk enhancers. And I actually think that those with CAC are sort of a middle ground. I call them sort of a 1.5 on the primary to secondary prevention scale. With really high CAC scores, you're starting to get risk of ASCVD, as you mentioned, similar to somebody with established disease. So you could sort of funnel them into this pathway and then, you know, treat accordingly. But I actually think that probably what we're doing is a little bit different, and a lot of preventive cardiologists sort of treat them as a bit of a separate group, and we're not doing further risk stratification. But if somebody has a CAC score of 300 or 400, or if they're young and have a CAC score that puts them in the, you know, top 5% of people, for example, I treat them very aggressively, particularly when it comes to lipids, and get LDL cholesterols down at least less than 70, ideally less than 55. Where there's a little bit of uncertainty still is in some of the other treatments like aspirin or other sort of secondary prevention therapies that we haven't seen as much robust data for in primary prevention. But as it relates to lipids, I treat people with high CACs like I treat people with established ASCVD.
Well, Mike, not to
Those people, I'm one of those people with a very, very high calcium score. So I was at 70 on atorva, and the ezetimibe wasn't really there, and then added a PCSK9 inhibitor and got down to 27. So, you know, I just want to be somewhere near a hunter-gatherer at this point. That's my goal.
Well, and if you think about the benefit of LDL lowering is proportional to the degree, the benefit of these therapies is proportional to the degree of LDL lowering. You know, going from 70s to 26, you've had you know, if we take CTT estimates, you've had greater than an additional 25, maybe 40% risk lowering based on that delta. And that sort of gets to Pam's point, which is 55 is the minimum. That's like getting a C on your report card. What you really want is to be solidly below 55 in a sort of comfort green zone of LDL control.
Yeah, I wanted an A on my lipid report card. So
you
and
got
Mike,
it.
you also have an elevated lipoprotein A.
yeah, 2 or 3 times the upper limit of normal. So that's why I'm doing everything I can to get down there.
So I think I think one of the most important things that we can do for our patients is really classifying risk and utilizing the tools that we need to, whether it's biomarkers, whether it's imaging like coronary calcium scoring, but it's very important. And I think in many practices, we just don't do those tests to understand the true risk of patients. So I think it's important. So now let's talk about what's really happening in clinical practice. And I always find this appalling that in real world, very few patients are even having their LDL measured after a PCI, and only 1 out of every 2 patients after they have an ASCVD event are even getting to that LDL level, which was less than 70 before. Now we're shifting to less than 55. Anne Marie, I know you've done a lot of research on this. What are your thoughts about this?
Oh, it doesn't matter where we look, or you know, the big databases, small databases, individual clinic practices, cross global analyses, we're doing a terrible job. And even in patients who are routinely seen in clinical practice by cardiologists, we get, I've never seen a study that is very different than this. At least 40%, if not more, patients fail to have an LDL less than 70. And if we look at less than 55, it's even worse. So now that we've kind of lowered the bar to be consistent with clinical trials that have shown that getting LDLs less than 55 confers additional benefit, very few patients are meeting this bar. And if we dig deeper, what it looks like is a lot of that is because very few patients are on combination therapy. So although statins are great and should be the foundation of lipid lowering in patients, particularly those who can tolerate them, most people are not going to get less than 55 on a high intensity statin alone. And we need to do a better job of combination therapy. And it's not all price and access, because even utilization of ezetimibe in most studies is in the single digits or the low teens. And ezetimibe is cheap, it's generic, and it's easily accessible. So we've got to do a better job at add-on therapy, starting with the therapies that people can afford, and then quickly escalating to other therapies as needed to get LDLs where they need to be.
Mike, your thoughts? I know you worked up in Gould Registry.
Yeah, I mean, it's appalling, right? And when you talk about not doing anything about it, we found that only 17% of the time did people up titrate the lipid lowering to try and get to goals. So people aren't even getting started. They're certainly not reaching the goal, and we're not doing really much to up titrate them. So it's a real public health failing. We have a lot of work to do. I have to say, with my lipids, I went to my primary care doctor, Harvard trained, former Harvard chief resident, gave him my numbers, and he said, "Oh, you probably don't need to have your LDL that low." And I said, "What?" He said, "Well, there's this doctor out at UCSF who says lower is not better, and, you're probably overdoing it here." So I had to get the articles and send them to my doc and educate them about the need, to go lower. So we have some real educational gaps. I mean, I've experienced it in my own life.
That's really crazy, but it's reality. And
It is.
What's interesting about low LDL, as you mentioned, hunter-gatherers. I mean, babies are born with an LDL in the 20s and 30s, and babies have kind of the most rapid period of neuronal development, and they do just fine with very low LDLs. And we've also seen in the natural genetic experiments in patients who have PCSK9 mutations, where they are born with LDLs in the 20s and 30s, and throughout their life, they have sustained low LDLs. They don't have any adverse sequela from the low LDL.
But they don't have heart disease. The sequela they get is incredibly low rates of atherosclerotic disease. And I think that point is very helpful when I talk to patients, that there are humans out there that basically have genetic mutations that make it look like they've been on a PCSK9 inhibitor since they were born. And the only downside for them is that they don't need a cardiologist in their future. So it's very, the genetics here are very reassuring. Even at a cellular level, Mike Brown and Joe Goldstein at UT Southwestern here decades ago hypothesized that the ideal LDL level is somewhere in the less than 30 range, because above that is where your body's sort of mechanisms turn on to try to lower LDL. And just one final point on this I think is really important is our blood LDL levels are not the same as what our cholesterol levels are in our brain. So our people worry a lot about cholesterol and brain function, but there's separate regulatory mechanisms there. These are drugs that are affecting LDL in our blood, but not LDL in our brain.
Great
And
point.
nature's already done the randomized trials.
Yeah.
Billions and billions enrolled unknowingly without their consent to these mutations, and we know the results. And also, it's different than being on a drug. With the mutations, you get a lifetime of exposure. And, I think we talk a lot about lower is better, but I think the future conversations more and more going to be about is earlier better. And, with my family history, my two sons have gone to their primary care doc. They're already on statins in their 30s. So I think that's a future conversation about when to start lipid lowering as well.
Great points. Well, now we can talk about some of the recent data from the ACC scientific sessions. And I want to start by talking about the CLEAR Outcomes study. And that was presented not this year, but last year, but we had some sub-analyses from CLEAR. So I thought it was good to start with the primary study before we delve into the sub-analysis. And CLEAR Outcomes was really a landmark clinical study that was looking at patients who had statin intolerance and who were undertreated, and looking at the impact of a novel compound, bempedoic acid, which acts upstream to where statins act. So statins act on HMG-CoA reductase, and bempedoic acid acts on an enzyme called ATP citrate lyase and decreases the synthesis of cholesterol. And what's really nice about bempedoic acid is it's not bioavailable in skeletal muscle. So the incidence of musculoskeletal side effects is almost negligible with bempedoic acid. So very well tolerated compared to statins. And what we saw in the main study is about a 13% relative risk reduction in MACE at 40 months, and the number needed to treat was 63, and it was very well tolerated. The study enrolled close to 50% women, also speaking to how women have a high degree of statin intolerance and are very undertreated. And then there was a sub-analysis that was done just looking at patients who fall into that high-risk primary prevention category, which Anne-Marie described as the 1.5. They're not secondary prevention and they're not primary prevention. These are the subclinical atherosclerotic disease patients that probably would have a high CAC score if it was done. And in this subgroup, we saw even more benefit with a number needed to treat of 44. So really incredible insights from this sub-analysis. And most recently, in March, the FDA expanded the label. And it was really nice to have this broad label, which allows us to give bempedoic acid to those patients that are either partial or complete statin intolerant, and also for patients who are high risk but haven't had an event. So this is a real important update. So your thoughts on this?
I'm delighted to see, the label update usually means that drugs become easier to get through payers and payer rejections. And, on the PCSK9 side of things, we've seen it really dramatically improve, first after the lowering of the price and just after people got more confident. In fact, I've had Repatha prescriptions that did not require a prior auth, that just sort of have gotten approved. So the landscape has gotten easier. And I think some of our bumps and bruises from PCSK9s have paved the way a little bit for other novel lipid lowering therapies. The rejection rates for bempedoic acid are not as bad as what we saw for PCSK9s in their first year availability. So I think we as doctors have learned a little bit about how to navigate that system. And I'm optimistic that with this label change, it's going to get even better. And so usually it takes a little bit of time for the payers to catch up. But it also usually means that we get better coverage and better access for our patients.
Yeah, and I'm really happy to be able to give my patients that are statin intolerant an option, because before, without this label expansion, we had, other than ezetimibe, we didn't have a lot of options for those patients.
It's
Yeah,
the
it's really,
only non-statin LDL lowering agent that's indicated in primary prevention. Is that right?
that's correct.
Yeah.
We've got outcomes data in primary prevention for a non-statin, which is great. And we have a therapy that you can tell patients, this drug has been studied in thousands of people just like you. We have studied it in people who can't take statins, and they are able to tolerate it very well. It's very safe, and it works to prevent events. And I think that's a very powerful message to be able to tell patients that that not only have we shown that it works to lower LDL in people like you, but it prevents events in people just like you, and we have tolerability data there.
Yeah, and so here was a recent presentation from ACC looking at a subgroup, and those are patients with obesity, and really looking at what the impact of bempedoic acid is in those patients. And we know in general, our patients with elevated BMI have more cardiovascular risks. They have a higher inflammatory substrate. And so what we're seeing with this sub-analysis is that there is even higher relative risk reduction in these obese patients. Your thoughts
Not
on
only relative risk reduction, but a big absolute risk reduction. When you're seeing a 3.2% absolute, that you don't have to treat 30 people to prevent an event. So that's pretty amazing.
Yeah, so this was a very interesting to see, especially now that obesity is being recognized as a bona fide disease, and we have a lot of different options for these patients. And it's nice to see that these patients derive even more benefit from lipid lowering. Here is another study that was presented at ACC, and this was looking at, again, a subgroup. This was a Hispanic and Latinx population, and they looked at that population with and without bempedoic acid and compared it to the non-Hispanic Latinx population. Anne-Marie, your thoughts on this?
And I think this is sort of not surprising that the drug works. There's not a lot of biological difference between Hispanic and non-Hispanic people, even, any race and ethnic group. There's very little or zero biological differences. These are sort of social constructs. So there's no reason to think that there would be any difference in drug efficacy. But it's nice to be able to have data in populations of people that look like the people that we treat. We do see that, for probably a lot of other reasons in terms of, comorbidities and where people are getting enrolled, that the Hispanic population was lower risk. Though both of those curves for Hispanic people were lower than the non-Hispanic folks in the trial, and still a big benefit in terms of a hazard ratio. And the clear outcomes data were also pretty impressive in that front. We're used to seeing attenuated benefit in primary prevention populations. The curves for statins tend to take a little bit longer to separate. But we didn't see that here. And we see very consistent results between high and low risk subgroup and subpopulations, which is great, and sort of reinforces that we shouldn't only be thinking about lowering LDL cholesterol in the highest of high risk groups, that even in low risk groups, we need to be treating. And, low risk is sort of what counts as low risk? I mean, even here, over 5%, nearly 10% of people are having an event by month 54. I don't want to roll a 10-sided dice to have an event. And here you get a 23% risk reduction in even that lower risk group, which I think is a compelling reason to, again, we need to lower these LDLs lower than where we're starting.
Right.
Some kind of provocative separation of the curves that are kind of early in the Latinx patients. Anne-Marie, when you said, escalate the therapy pretty quickly, what do you mean? I mean, how long should we wait to be adding on, these therapies?
Well, geez, we've had statins for decades. We haven't seemed to get them into the population all around. So, the answer is like yesterday. But to not be so tongue in cheek, most lipid-lowering trials do show that it takes about a year to start seeing consistent separation of these curves. I think that this may be a little bit of statistical noise that you're seeing in the blue part of this curve, but pretty consistently in LDL-lowering studies, you see a lag, and even if the curves start to separate, they really start, the separation increases starting after about 12 months. So I think about LDL lowering as compound interest works for saving money in the bank. The earlier you start, the more benefit you're going to get over time. And you've got to get on drug and you've got to stay on drug for it to keep working. The one of the reasons why I think we need to sort of push for earlier, though, isn't just because you want to get this clock started, but is because this is when the therapeutic inertia is the lowest. So patients, after they've had an event, are usually very activated to get, what can I do, doc? Like, how can I not have I don't want another heart attack. I don't want another stroke. I don't want to have to get my leg revascularized again. And so they're really interested in getting on therapies to keep this from happening again. And I think they're coming to the doctor more often, and doctors are usually more likely to sort of say, well, now that you've had an event, let's look at where you are and see what therapies need to be changed. So it's a really good activation window to be thinking about up titration. So that's really the, practically beyond just the curves, reasons why we should be doing getting patients on therapy and getting them to goal early, because that's sort of an opportunity of energy on the patient side.
But give me a number. So if I had my LDL of 70, I mean, how long should you wait to get me on double, triple therapy?
The next time you're seen. I mean, I think there's no reason to wait. I would, give you 6 weeks on whatever drug you're on, maybe 3 months if you really want to be sure you're at absolute steady state. But if I see somebody who's post MI, they get put on a high intensity statin, and I'm seeing them in clinic follow up a month later and their LDL's 100, I'm not going to wait to add on more therapy. I think in fact, even upstream from that, I've started using a lot more combination statin and ezetimibe out of the gate.
Right from the start. Yeah, me too. Yeah.
Because then you don't have to, you're sort of shortening all the steps, and you see where somebody lands then at follow-up. But I think we should be iterating this. And when I order a new lipid-lowering therapy, I automatically order the follow-up LDL. I tell the patient they need to come in for it. And I don't wait for the next clinic visit. I give them, okay, if your LDL is still over 70, we're going to start XYZ. We talk about therapy options, and we have it sort of preloaded as a plan to trigger. So there's no, I guess my answer is don't wait. Do it as soon as you can.
It's a little bit like heart failure, escalate quickly, right?
I mean, for patients, if someone came in with a hemoglobin A1C of 9, you wouldn't just start metformin and wait a couple months. I mean, that they're going to need multiple agents and you're going to start it up front. And similarly, if I saw a post-MI patient and their LDL was 130, and they're already on maximally tolerated statin, just adding Zetia isn't going to get them to less than 55. It just isn't statistically. I mean, Zetia is going to give you 15 to 17%. So you automatically know you have to add multiple agents. So that might be a patient that you might think about a bempedoic acid plus Zetia combo that's going to give you close to a 30% LDL reduction. So I am very aggressive of just starting multiple agents at once, or I have a little bit of priming like Anne-Marie described, where we'll check it again and then we'll quickly have a plan to add on. But that's what we do for diabetes. That's what we do for hypertension. And that's what we need to do for lipid lowering.
Yeah.
But it starts with
better,
giving
but quicker is better too, right?
There's so few patients, not so few, but big swaths of patients, up to half of patients with ASCVD in clinical practice do not have an LDL documented in the last year to 2 years. These are patients who are seen in clinic, and we've looked in EHR data across the nation, and nearly half of people had no lipid panel in the prior 2 years.
So this is another abstract that was presented, and this is looking at males versus females who got bempedoic acid. and want to hear what your thoughts are on this.
I mean, I think this is the same takeaway, right? There's, it works in men and women. There's, consistent results between the two. The interaction p-value is practically 1. So, similar benefit in men and women. Again, women have lower event rates than men. This is not front page news, but even in women, there's a, nearly 10% risk of recurrent events at 54 months. So, a relatively lower risk group is still at high risk of events and still benefits from bempedoic acid. I also want to point out what the clear outcomes was really just looking at that single agent of bempedoic acid. But what I use a lot in clinic is the combination bempedoic acid with ezetimibe, which, as you just mentioned, Pam, gets you a much greater LDL delta beyond bempedoic acid alone. And so I actually think that many of us were surprised at the hazard ratio here, because we thought that, just bempedoic acid alone may not be lowering the LDL sufficiently to really separate those curves that much. So, if you can extrapolate logically, if you add ezetimibe to this with an additional 15 to 20% lowering of LDL cholesterol, your hazard ratio would be even greater. So I just want to mention that when you see a hazard ratio of 0.86, that's for just the monotherapy component. If you add in the delta that you would get from ezetimibe, the benefit on MACE would have been greater.
Yeah.
But the other thing to realize is you're talking about a 20% event rate. A 15% lowering on a 20% event rate is almost 3%. So I'm one of those people in red there. I'm looking at you don't have to treat 33 males to get 1 event reduced. So the relative risks are the same, but the absolute risk reduction may be bigger in men.
Yeah. And what's really nice about this trial is close to 50% women. So the women are well represented in this, and so you can really say what are the differences between men and women based on the numbers that were recruited. So let's talk about one of the other studies, and this was the Victorian Initiate study, and this is with the novel PCSK9 silencing RNA inclisiran. And what inclisiran does is it decreases the synthesis of the PCSK9 protein. But what's novel about inclisiran is it can be given every 6 months, and it really helps with adherence. And so in this study, what they did is they compared usual care to giving inclisiran first in these patients with ASCVD. And then they looked at what was the LDL that was achieved. And they found that the strategy of giving inclisiran first, more patients achieved low LDL goals. So 72% had an LDL less than 55, versus only about 9% that got usual care. So I thought this was very interesting data. Your thoughts, Anne-Marie?
No, I mean, just again, a failure of usual care. I think that, it's nice to have multiple options. I'm not sure that there's anything specific to the inclisiran platform here. It's really just getting people on therapy that they stay on, will get their LDLs down, but you have to actually do it promptly in order to see a benefit. So, the choice of agents now is really going to depend a lot on shared decision making. Does somebody want to take a pill or use a shot? If you want to have a shot, do you want to give it to yourself at home, or do you want to come into the clinic to receive it? Do you want one that can be every 6 months, or are you able to do something every 2 weeks? There's very few medical differences between the groups. If you have gout, you probably shouldn't be on bempedoic acid, but besides that, it comes down to patient preference, and then out-of-pocket cost and what's covered by insurance. But I think this is just sort of we saw similar data from EvoPax, looking at evolocumab post ACS, just sort of, early initiation of therapy is going to beat usual care every time.
Again, as you eloquently stated, our usual care is horrible, as we've seen from so many different registries. So
But
now,
we do get rejected often, and I was rejected for inclisiran, and I am part of a group that's going to be meeting with multiple payers to lobby to accelerate the use of PCSK9 inhibition because it's in their interest to get people to goal quickly.
so we'll turn it over to you, Anne-Marie, to tell us about what's new on the horizon.
Sure. So we'll sort of quickly go through, we've had a wealth of new therapies and lipid lowering in the last decade, and it's not slowing down anytime soon. So on the PCSK9 front, we have inclisiran, which is FDA approved, which came on the heels of our monoclonal antibodies, alirocumab and evolocumab. The outcomes data for inclisiran from the Orion trial, we anticipate coming around the corner soon. So that's going to be a exciting time to see if and how much it reduces events. There's two other monoclonal antibodies that are listed here on the slide. The REMAIN-2 trial was presented at AHA in 2023. It's a monoclonal antibody that's dosed every 1 to 3 months, so you get a little bit more spacing out. There's an oral PCSK9 inhibitor that has been developed and is in phase 3 trials now. That's the Coral Reef program. And so the outcomes trial is enrolling and underway now. And then perhaps some of the more interesting or innovative stuff is actually in gene editing and trying to recapitulate that phenotype that we talked about earlier of having a gene modification. And that Verve Therapeutics has now done some early studies of being able to do gene editing to turn off PCSK9 altogether in the liver. Next slide.
It enrolled their first patient this week in the 102 study.
Yeah.
So that was good.
Yeah, I think particularly transformative potential for people with FH who, even with all these therapies often struggle to get to goal. CETP, our old friend, is not dead. So CETP, just as a reminder of what it does, is helps move cholesterol ester between HDL and LDL particles. So if you inhibit it, you get more cholesterol ester in HDL particles. And those HDL particles are the particles that take cholesterol out of your system and bloodstream back to the liver for excretion via bile. So if you inhibit cholesterol ester, you can both raise HDL cholesterol and lower LDL cholesterol. Next slide. We've met CETP inhibitors before, anacetrapib, evacetrapib, dalcetrapib, and torcetrapib. And what I want to point out is that not all CETP inhibitors are the same. If you look at the second cluster of boxes here, the degree of LDL lowering that you see with different CETP inhibitors is highly variable. In fact, dalcetrapib has almost no benefit on LDL cholesterol, torcetrapib only a modest benefit. Eva and anacetrapib had a bigger benefit. These drugs were actually initially developed because we thought that raising HDL cholesterol was going to be good for you. And so this sort of was targeting the HDL hypothesis, and that was ultimately disproven. But there is some thought that actually their benefit may be present via their degree of LDL lowering, or perhaps more importantly, their degree of ApoB lowering. So we go to the next slide. A latest CETP inhibitor that is being studied is obicetrapib. Obicetrapib substantially reduces LDL cholesterol. This has been studied in the ROSE trials. It also substantially reduces lipoprotein A, so an over 50% reduction with the higher milligram obicetrapib in the ROSE study. Next slide.
I just wanted to comment, we mentioned that Mike has an elevated lipoprotein A, and so this is a very appealing compound because it's oral and it has both an LPA lowering effect as well as an ApoB lowering effect.
That's why I come onto these presentations so I can find out what drug I need to go try and get for compassionate use.
Or you could perhaps join the cardiovascular outcomes trial, which we'll talk about.
Okay.
There's some genetic studies we've seen, just like people who have genetic mutations that look like statins or PCSK9s or ezetimibe, people with genetic mutations that look like CETP inhibitors have lower rates of cardiovascular events when you standardize per the degree of LDL lowering. Next slide. So we have genetic data that suggests this may work. There's actually trial data that suggests it works as well. So the REVEAL trial studied anacetrapib, and at 2.2-year follow-up, there was a 20% reduction in cardiovascular events. And then over the full duration of the study, there was a 12% reduction in major coronary events. And that's with a less ApoB lowering drug than what is seen with obicetrapib. So some suggestion that this may actually be a therapy that could work, although the development of anacetrapib was not continued. Next slide. Intriguing data from CETP inhibitor trials suggest that they may also protect against the development of new onset diabetes. So these are pooled data from 4 cardiovascular outcomes trials looking at new onset diabetes in people given CETP versus placebo. And the pooled estimate was 0.84, so a 16% reduction in new onset diabetes with some heterogeneity between trials, but consistently on the left side of one, so a consistent effect of less diabetes. So unlike statins, which do slightly increase the risk of diabetes, this potentially could lower that risk. Next slide. So the cardiovascular outcomes trial for obicetrapib is underway now. It's called PREVAIL. It is randomizing people to obicetrapib versus placebo who have established atherosclerotic cardiovascular disease with additional risk factors, and this will be a trial that's looking at 4-point MACE and whether obicetrapib lowers cardiovascular events. And the trial will also be studying the impact on diabetes and some of these other sort of intriguing endpoints. We're interested in safety and efficacy of the drug, obviously, first, but also some of these other exploratory hypotheses I think will be interesting to see. So the future is bright for LDL cholesterol, hopefully. At least we have more outcomes trials that will continue to show us if we have new options for our patients in the future.
Thankfully, Mike, looking at this inclusion criteria, you're not going to qualify. Your LDL is in the 20s, so good thing you're not going to qualify for the outcome trial.
Yeah, this does bring up an interesting point, like it does for all the CETP inhibitors, which is if you're already on an LDL lowering agent and you add this, what would be the benefit? And when you look back at the Mendelian randomization data, there are some people who have, multiple mutations, and the data is not that compelling when you have both mutations. So it'll be interesting to see what happens here.
Yeah, and the one thing I'll note on this is that the inclusion criteria here is an LDL over 55. So, one of the, to date it's been 70, 4EA, Odyssey, if you're you had to have an LDL of 70 or above. Here, they're actually lowered the bar to 55, sort of recognizing where, guidelines have gone or are going for LDL lowering.
So Anne-Marie, take us back through the questions and we'll give the answer now.
Yeah, we'll just click through what makes someone very high risk. We're looking for A and B. So you've got oh wait, hold on. Did I get that right? So ischemic stroke over 65 and with diabetes. So you've got 2 of the very high risk conditions and 1 major event. So that's sort of 1 from the major. And then the second one is sort of the gimme, right? You've got an MI and you have every risk factor listed here. So
You know, when we first put this poll up, it just went to D and it didn't have option E. And I
Yeah,
thought, oh boy, I'm not sure about this poll.
I had the same thought. I thought, ooh, did
Yeah,
we missed it? But no, we forgot
yeah,
to go to answer E,
yeah.
with A and B. DVT is actually not, so the, venous clotting events, although share risk factors, does not count as ASCVD. So this is not an atherosclerotic event. Now, if this was somebody with peripheral arterial disease, with hypertension and age over 65, that would be a different story. We do know from lots of observational data that PAD and ischemic cerebrovascular disease are equally poorly undertreated compared with coronary patients. So people think more about lowering LDL and secondary prevention in people with heart disease than non-cardiac atherosclerosis. So I think the answer here, what should your LDL level be after a CV event, should actually be none of the above, and it should be, several undersigns, less than 55. The data are consistent that in LDL lowering trials on treatment LDL, you see a consistent benefit with lower cardiovascular event rates with lower LDL cholesterols, even below 55. Fourier Odyssey got patients LDL well into the 20s and 30s, and just as a reminder of the safety of that, a very in-depth additional sub-study on Fourier called Ebbinghaus looked at cognitive outcomes and did extensive cognitive testing in people on evolocumab versus placebo. People who had LDLs into the teens and no cognitive differences, no differences in cognitive performance across domains. So your LDL level should be at least below 55, if not lower.
So that was a great overview of what we saw at ACC, and I think also in general about future therapies and where the field is going.
Well, thanks. Let's now turn to the audience. We have about 30 participants, and it's time to open up the lines. Anyone have any questions for us? While we're waiting, there has been an uptick in age-adjusted cardiovascular mortality for the past few years. Why do you think that's the case?
Well, there's a few pieces to that. We did see an increase in cardiovascular deaths with COVID because COVID, a lot of people who died from COVID or with COVID had cardiovascular events triggered. So there probably was a spike that was sort of artificial from COVID. I think there's another kind of issue around just more of a survivor bias that, we're better at treating mortality rate is going to be 100% for humans. So you got to die of something. And so, as we improve survival for other things, it's sort of, what's left. And we've also gotten better at coding things. So, people are more likely to, if they have heart failure, get it coded as heart failure, and then it's called a heart failure death. So some of this is just, I think, improved surveillance. There is globally a trend that's increasing, and a lot of that is actually driven by increases in cardiovascular death in low and middle income countries, where the risk factors, hypertension, smoking, remain even worse controlled than what we have here in the United States.
And
But this was US age adjusted, and it did precede the pandemic. I mean, there's been some concern that the kind of pull away from a target, LDL target in some of the earlier iterations of the guideline may have caused us to ease up a bit. I mean, what do people think?
I think that is actually a really important factor because the older guidelines just said, put them on a high intensity statin and that's all you need to do. You don't need to really look at your results. And we know that there can be heterogeneity in statin response. Even if you have somebody on a high intensity statin, if they have an elevated lipoprotein A, they may not have as much LDL lowering. So you really have to evaluate your treatment. And that's where I think the newer guidelines, where we at least have a threshold that we need to achieve, is important. But I also think in general, we saw the data in real world clinical practice. We're not using combination therapy. So we need to really start shifting the paradigm of using combination therapy for lower LDL targets.
Yeah, I also think the multimorbidity is increasing. Just, in the United States, you now have, it's almost, you almost never see somebody that would be low risk ASCVD. Almost every patient that I see in my clinic for secondary prevention has multiple things that we're dealing with: hypertension, diabetes, obesity, inflammatory disease. There's just a lot more sort of gas on the fire here. And as the rates of diabetes and hypertension have increased, and as obesity rates have increased, I think that our patients with CVD become more complex than they used to be.
We have a question from the audience. Do you think the next iteration of the guidelines will recommend upfront, right away, combination therapy for high-risk patients, irrespective of initial LDL?
Oh, I wish they would. I think that the challenge here is going to be where there's clinical trial data, and that's where I think the consensus statements and some of the expert opinions can really be helpful, because the guidelines are very strict in the sort of sticking with what clinical trials have shown, and kind of going in that order. So they may not, just because of how some of the trials have been done. So they may not say to start up front. I do think there will be an emphasis on early initiation and rapid up titration. Pam,
Where
what do
does
you?
Ozempic fit in all this? I mean, you get your weight down, you get your LDL down, your HDL up, you get your hemoglobin A1C down, your blood pressure down, your CRP down. You might even stop smoking. I mean, so are we missing a boat here? I mean, rather than up titrating all these medicines, should we start people on Ozempic if they're, BMI at 27 or higher?
Yeah, but there are also a lot of people that have a normal BMI that have very
That's why I said a 27 or higher. I mean,
but I think that sometimes I think we need to keep in mind that LDL is still the most modifiable risk factor that's going to give us the most bang for the buck. Yes, we need to treat all of these other concomitant conditions like obesity. And what I find is the GLP-1 receptor agonists, along with lipid-lowering therapies, are very synergistic and help us actually get to lower goals. So I don't think it's one or the other. I think it's actually, depending on the patient, a very personalized combination therapy, and not just for LDL lowering, but also for all of their other comorbidities.
Yeah, I mean, even in SELECT, the mean LDL was in the high 70s. This was the cardiovascular outcomes trial for semaglutide, and it was an established ASCVD. So still room for improvement there. Most of these trials are emphasizing sort of solid background therapy, and I agree with Pam. It's not, the arteries are not deficient in GLP-1. It's cholesterol. I mean, it's cholesterol that's getting into the artery walls. It's when you look at pathology of it's cholesterol plaques that are rupturing. We got to focus, treat all the risk factors, but just because you're treating one doesn't mean you don't have to treat the others. And a GLP-1 is unlikely to get your LDL where it needs to be. That said, I think that all of these things work together, and they don't obviate the benefit of the other. We wouldn't say you're starting a GLP-1 so we don't need to treat your blood pressure, or you don't need to stop smoking. We say you need to stop smoking, and we're going to treat your blood pressure, and we're going to treat your obesity, and we're going to get your LDL to goal. And I think that all of these things together work. And there are no trials where in the treatment arm, the risk goes to zero. So none of these therapies on their own is sufficient to take somebody's risk all the way down. Our hope is that if we kind of add up all of these therapies, we progressively lower somebody's risk.
It is interesting. I mean, it's provocative from some of the semaglutide data that the risk difference begins kind of early. I mean, the separation of the curves begins fairly quickly. I think that is the multiple risk factor reduction that we're seeing there. I always love to ask questions like one or the other, knowing that the answer is always both, that they're complementary strategies, not competitive strategies. And then, I think there is some good, talking about plaque, there is some good regression data showing that you do a lot like what you do with statins. You actually increase calcification and reduce low attenuation plaque with weight reduction. It's a little bit like me. I've been on statins a long time, have very calcified arteries, but not much low attenuation plaque. I want skinny arteries too. I want to be skinny and have skinny arteries, both. Well, any final comments from you two?
Pam, why don't you go first?
No, I think what we've covered is really a wide spectrum of options for LDL lowering. We've highlighted some of the recent data that's presented at ACC, and also learned about some of the new therapies that are in clinical trials. So I think in this past hour, we've really covered a lot.
Yeah, I think the message is really consistent. We need to do better. We have to measure LDL cholesterol more frequently in our patients. We have to up-titrate therapies. We have multiple options for LDL lowering beyond statins. We even have multiple statins. So we really have no excuses anymore. The payers are covering these drugs. There are options for patient assistance programs. It can take some work for the providers to deal with the prior auth, but we just have no reason to not be doing better except therapeutic inertia.
I guess I do have one final. Let's get our LDLs down to what the babies have in the 20s to 30s.
I'm there. I mean, I don't know what to say. Well, your science, your basic science, your clinical science is only as good as your implementation science. And you can have all the drugs in the world, but if we're not taking them and staying on them, we're not going to do anything. So we got to do better in implementation. Thanks, you two. Thanks for joining us, and thanks to all of you in the audience for joining us tonight.